Welcome to this CSI webinar on Tavi, Contemporary Practice. This is going to be a case-based webinar. So we're going to start with a case and discuss all the topics that are around this specific case and how to handle this. The webinar here is sponsored by Boston Scientific. My name is Lars Sondergaard. I'm an interventional cardiologist based in Copenhagen, Denmark. It was a great pleasure to be joined by Magnus Zettergren, who's also a cardiologist from Karolinska in Stockholm, in Sweden, and Thomas Modin, a cardiac surgeon from Bordeaux in France. And also we have Martin van Haberweg, a cardiologist from Belgium. So, and also Martin is going to be our chat master. So if you have any questions, please address them to Martin and he will try to bring them into the discussion. And there will also during the webinar be a chance for you to go live if you have something you want to discuss. So we hope that we can have as interactive session as possible here. As I said before, it's going to be a case-based session here. So see if I can share my slide here in a second. So we are going to start with the case presentation, the case we're going to discuss, and also going to see the recorded procedure later on. And Magnus, maybe you will take us through this case here.
Sure, no problem. So the patient that we are going to discuss today is a 67-year-old female. She has hypertension, diabetes, chronic renal failure, and severe aortic valve stenosis, severely symptomatic, functional class 3. And as you can see, a fairly normal lady in Denmark, I would say 164 centimeters and 87 kilos. Next slide. And the pre-procedural investigations, including then an echo showing a highly significant aortic stenosis with a mean gradient of 94. Although the EF is reduced by 35%, she is still in sinus rhythm, narrow QRS, and a PR interval. The CTA, including the coronaries, did not reveal any severe stenosis that required intervention. She's a little bit low in hemoglobin. eGFR, as we mentioned previously, reduced by 30, and then calculated SDS score of 1.8%. So if we look at the cardiac CT, so it's a little bit of a teardrop shaped annulus here that measures 19 by 23 millimeters. Perimeter derived diameter is 22. The LVOT is slightly flaring, measuring 22.2 millimeters. And the sinus of Valsalva is rather narrow, measured around 28 to 29 millimeters. The STJ, as you can see, almost a napkin ring calcification there, and it's also fairly narrow. Severely calcified leaflets, and primarily at the leaflet tip. Not a lot of calcium at the annulus, actually. So, and as you can see here, we have a good takeoff of the coronaries, both right and left. There are some calcifications at the ostium of the right coronary. Left looks fine. And we can also again see the calcification at the junction of the STJ. So this is a little bit, so to the left, you have the cusp overlap view, and then you have the three-cusp coplanar view to the right here. And this is then both for later for the positioning of the valve, but also to do commissural alignment. The aortic arch is pretty standard for a TAVR case. I would say some calcium in the arch. The neck vessels should be able to accommodate cerebral protection with a Sentinel device. Also, the transfemoral access looks favorable, especially from the right. There are some calcium in the iliac arteries, but the diameter is at the lowest is 7 millimeters, so shouldn't be a problem for transfemoral access in this case.
Okay, so thanks, Magnus. So just if I should summarize, I see this is a relatively young patient. She's 67 years of age. So some sites will prefer to do a surgical aortic valve replacement. Other sites will maybe consider TAVI because of the comorbidity, a little bit obese. She have impaired renal function. So there will be different options in this patient here. The other thing I see is that she got relatively small aortic annulus. It's 22 millimeter. People will use a cutoff between small and large aortic annuli of about 23 millimeters. So she is in the lower range here. Of course, you have to adjust it to the patient's the size of the patient. We saw this patient is pretty big. I mean, she got a body surface area of 2.0 square meters. So that's some of the issues. Other issue is that even though she have nothing to any coronary lesion which needs to be addressed for the time being, we need to make sure we can get into these coronary arteries later on, both because she have some borderline lesions on the LAD and also due to her age. I mean, she could have a longer life expectancy. So it's also important to preserve access to the coronary arteries. But if we start with the first issue here about her body size, BSA of 2.0 square meter and her relative small aortic annuli, I would say she's probably a patient, who could be at risk for patient-prosthesis mismatch.
So I completely agree on that. And this is also something that we always take into account nowadays when discussing these patients. So even she is 67 and she has some comorbidities. I think the size of the annulus should always be in the discussion when we discuss these patients. And there is a paper out there now in JACC just a couple of weeks ago, again showing that if you have a severe PPM after surgery, your life expectancy is reduced. So this is definitely something we need to address during the MDTs. And I think we maybe have not done that properly previously, but we are getting there.
Yeah. And particularly in these younger patients, I mean, I think everyone agrees that you have to consider the lifetime management of these patients, not only focus on how to get the first valve in safely, but also to make the valve last a long time and also be suitable for later re-intervention. And of course, durability is going to be important in these patients at a younger age. And I think one of the main drivers, we're going to discuss that here, for early valve failure, if you have patient-prosthesis mismatch. And as we said, it's not only for surgical valves, it's also for transcatheter heart valves, for all bioprosthetic aortic valves. And we have seen the surgeons are now using these bioprosthetic valves in younger and younger age. If you look into the guidelines, the recommendation is to use mechanical valves in patients less than 65 years of age and use bioprosthetic valves in older patients. But we see that most places, mechanical valve has almost completely disappeared, at least in our institution in Copenhagen. I don't know how it is in Stockholm, Magnus.
I think they are still doing a bit of a mechanical valves here for several other reasons, but I definitely it's getting less and less every year. And I think it's also important here because we know that this patient will be needing at least one more intervention during her lifespan, hopefully. So it's even more important not to have any type of PPM in these patients, not even moderate, because the second intervention could then be hampered by even a moderate PPM, actually.
How is it?
While you're having the discussion, I would invite the participants, if they have any suggestions on how they would treat mechanical valve, surgical, or a percutaneous valve, they can post their preference so we can have an idea what the audience would do at this early stage of the case.
So again, if you choose these bioprosthetic valves, whether it's surgical or transcatheter, it's important to make sure that the valve have as good a durability as possible. And I think everyone would agree on today that the main driver for early valve failure is if you have patient-prosthesis mismatch. And these are the current definition of how to define it. So after valve implantation, you measure what we call the effective orifice area. How much does the valve actually offer in opening area? And then we divide it with the body surface area of the patient. And if it's 0.65 or less, the patient has severe PPM. If it's more than 0.85, it's insignificant. And between 0.65 and 0.85, you have this moderate PPM. And I'm just going to show you a few slides because if you just go 10 years back, 10 years back, there will be people who would arguing that having patient-prosthesis mismatch would not affect the outcome for the patient. But I think we have seen consistent evidence that that's not the fact. You can see this recent meta-analysis here showed that if you have patient-prosthesis mismatch, the risk of early valve failure for valve failure is twice as high as if you do not have any patient-prosthesis mismatch. And it's not only the durability of the valve, but also the clinical outcome for the patient. So patients who have just a moderate PPM have about 30% increased risk of cardiac-related mortality. And if you have severe PPM, it's more than 6-fold increased risk of cardiac mortality. So again, coming back to the discussion we had before, I think this patient is certainly a patient where we need to look for PPM. She's young, she's 67 years of age. and she had a small aortic annuli, 22 millimeter. She got a large body surface area of 2.0 square meters. So, Martin, how would that discussion be in your institution? Would you discuss that upfront, the risk of PPM, and would it also direct the way you treat this patient?
Yeah, sorry.
Martin,
Magnus,
go on.
please.
Go on, Martin.
No, so in my institution, we would for sure discuss that with the patient because you know that it will degenerate faster, the valve. On the other hand, doing a root enlargement is a complex procedure, so that's not always an option. There are some surgical valves with supraannular position as well. So we would discuss that with the surgeon and see if we choose for a surgical procedure, if there's something available which has a low gradient. And then again, depending on the comorbidities, if the patient has some comorbidities, she is 67 years of age, you still might want to consider that percutaneous option as well. So that's the discussion we would have, indeed.
And in Stockholm?
No, yeah, no, again, I just echo what Martin just said. So definitely annular size and the risk for PPN is on the table when we are discussing these patients, at least the last 2 years, I would say. And that's why I also like to stress the importance of having a CT done on all the patients that we discuss for aortic interventions, not only the ones that where we are considering TAVR. Actually, I think everyone should have a CT today, even the younger patients, just for these reasons, actually.
I think what you're saying here, Magnus, is really, really important, because if you do not have a CT scan up front, particularly in the younger patient who are likely to go for surgery, you don't know what the risk is for having patient-prosthesis mismatch. And also the chance that the surgeon will actually do a root enlargement is much less than if it already looked at up front. And also there are differences between the risk of, let's say you do not do root enlargement, we can come back to that in a minute. If you do not do it, the likelihood that the patient will have a specific patient will have severe PPM is higher if you send them for surgery than if you send them for Tavi. Is that correct?
I agree. I mean, again, we need to move away from risk-based discussions to anatomy-based discussions as well, I think. And again, the CT is not only important for annular size, also it's important for us where we can assess whether TAVR is going to be a good option or not. We can have patients who are 80 years of age who is actually not a good TAVR candidate and should be done surgery on. So we cannot just look at age and other risk factors. We need to look more on the anatomy to have a good outcome in our patients. And then we need to include CT on all the patients.
Yeah. And I also think, I mean, one of the reasons that surgical valve is associated with a high risk of PPM is that you have this suturing, which take up some of the space in the aortic annuli. So you're getting out with a smaller effective orifice area than if the same patient would go for Tavi, particularly using self-expanding technology. So that's certainly something you should take into your consideration at the heart team. And actually, if you go back here, looking at what the surgeons have, the surgeons can actually have this matrix for all kind of valves. So they can look on a specific valve. This is for a mosaic valve. So if they have the patient in front of you, and the surgeons know what is the size of the patient, what is the body surface area, and what size valve can go into the patient, they can actually, before they start the procedure, predict what is the risk of having this green that will be an insignificant PPM or no PPM, or the red one here that will be a severe PPM. So they have the tools. They can already up front, before they start the procedure, predict the risk of patient-prosthesis mismatch. And as Magnus was saying rightly, that can only be done if you have a CT scan up front. And I think this is like many contemporary heart teams flowcharts look like today. So you see you have a patient referred with severe symptomatic aortic stenosis. We used to do all the clinical examination and echocardiography and so on before we had the heart team discussion. But I think in many institutions also now have the CT scan up front. It's not only a patient who at the heart team has been turned down for surgery and referred for Tavi, where we do the CT scan. Everyone will have a CT scan up front because it carries so much information. One thing, as we're discussing now, is what is the risk of patient-prosthesis mismatch? Should that change how the heart team is actually counseling the patient if there's a risk of PPM? We had the discussion a few years back with our surgeons who were somehow reluctant to do CT scan on every patient. But since we started, I think they're very keen to do it, to have this information up front. And I would also say, since we started to do it, CT scan routinely on all patients referred with aortic stenosis, I do not personally recall when I was last called to the OR because they had a patient where they had opened the sternum and found a porcelain aorta and they couldn't clamp the aorta. I mean, that's completely gone now. We don't see that anymore. So I think CT scan early in the part of the workup is really important to optimize the outcome for the patient and also make the right decision for how to do it. So I mean, and again, some of these patients will go for surgery because maybe very young age or something, they're not suitable for a Tavi procedure. It could be poor vascular access, very hostile aortic valve anatomy, and they will go for surgery despite of a small aortic annuli. You said before, Martin, about root enlargement. That's something which could be done in these patients. Is it routinely done in your institutions in Belgium, and how is it also in Stockholm?
So as to my experience, it's a procedure which is not frequently performed. Also in the chat, I have some comments. Salim Aziz suggests that it should not be technically challenging or difficult in an experienced center to do a root enlargement. So I was Magnus, what is your opinion?
I mean, this is what I hear all the time from my surgeons as well, that this is actually not a very complex procedure to do if you're in a larger center and so on. But honestly, I can't remember when it was done here at Karolinska. So I hear it all the time. It's like, no, it's not very complex, but still it's not done. That's my experience, at least.
Yeah. I got the same experience from our institution. It's not done. I would say one thing is that there has been more focus on root enlargement. I think the randomized clinical trial we have seen comparing Tavi and surgical aortic valve replacement and also some of the durability data have maybe highlighted for the surgeons that they need to do a better job if they want to give the patient a valve which have the same durability as transcatheter heart valves. And root enlargement is one way to move forward. But again, it seems to be done very infrequently. These are the data I have could find that it's less than 1% of the patient undergoing surgical aortic valve replacement who are offered root enlargement. So most of the patient with small aortic annuli going for surgery will come out with a small surgical valve with patient-prosthesis mismatch, and as I said before, with the risk of early valve failure and also increased cardiac mortality. So I think this is something everyone needs to work on in the heart team. First of all, to identify the patient who are at risk for PPM, and also how do we treat those patients best? Are they better off going for Tavi, or if they're going for surgery, will the surgeon offer a root enlargement? And if he wouldn't do it, maybe we should consider other options for these patients. So I don't know, but is it something, as I asked you before, is it something you routinely discuss at your heart teams? That do you have these measurements of the annulus, and will you discuss it with your surgeons how to treat those patients if he will bring the patient in for surgical aortic valve replacement? Magnus?
Yeah, at our institution, yes, it is discussed. Yeah, so our surgeons actually just recently published in JACC just like 2-3 weeks ago, actually on PPM. So I think the surgeons are at our institution also very much aware of the risk for PPM and also the bad outcome of at least severe PPM. So yes, it is discussed.
And I can add to that we started doing more CT scans, as Lars already introduced, and because of the Tavi field, we also do CT scans in non-Tavi patients, and it helps the surgeon to know what he will see and what he will encounter. So that for sure also opens a discussion, and sometimes even redirects patients from a certain treatment option, surgical to percutaneous or vice versa. So it definitely helps to do the CT.
So now we're talking about the risk of patient-prosthesis mismatch, mostly related to patients sent for surgery, because we know that's something we know is a risk. But I'm also just going to share a few slides showing that it's not only for patient undergoing surgical aortic valve replacement, but it can also be for patient undergoing Tavi. I'm not sure everyone appreciate that since the design of these transcatheter heart valves are different, they're also going to offer different hemodynamic performance and risk of patient-prosthesis mismatch. So this is just 3 valves here. You see the portico valve and now the navitor valve is a self-expanding technology with a cylindric inflow portion. So the red arrows is illustrating that the leaflet can open 90 degrees up, fully open. You have the Evolut platform, which is also a self-expanding technology now with a supine leaflet position, but you see the inflow portion is tapered, so there will be some kind of restriction in the leaflet opening. And finally got the Sapien platform, where if you look into that valve in your cath lab, you will see that the leaflets are actually sutured together in the commissure. So it's a tapered leaflet configuration. So also here, the leaflets are not opening fully up. And these different designs will, of course, as I said before, also impact the hemodynamic performance and the risk of patient-prosthesis mismatch. So if you go to this study, it's actually a randomized study here, randomizing patients between these 3 platforms. And you look at patient particularly at risk of patient-prosthesis mismatch, patient who have a small aortic annulus, again defined as 23 millimeter in diameter or less, and look at PPM at 30 days, you can see that the 2 self-expanding technology have the same rate of severe PPM, it's around 3%, whereas about 25% have moderate PPM. Whereas if you look at the Sapien platform, it's a much higher risk. It's about 1 out of 4 of these patients who have severe PPM, 40% have moderate, and only 1/3 of the patient have insignificant or no PPM. So certainly also valve design is going to impact the risk of PPM. We can also see another two randomized trials. These are the Scope 1 and Scope 2 trials. Scope 1 was randomizing patients between the Accurate Neo platform and the Sapien 3 platform, and you can see, as expected, the self-expanding technology is going to give you a larger effective RFS area and thereby lower rate of PPM. And if you look at the Scope 2 randomizing patients between the Accurate Neo and the Evolut platform, again, 2 self-expanding technology, both with super and leaflet position, there are no difference in PPM. So again, it seems that if you have a patient at risk for PPM, if you choose a self-expanding technology, the risk of PPM is less than if you use a balloon expandable technology. You may ask, do we have any data to support this? We have limited data on durability of these valves, and it's only going out to 5 years. If you ask a surgeon, he will say 5 years is nothing. Even a poor valve will make it out to 5 years. You have to wait 8, 10, 15 years before you really get the true durability of these valves. But this is the nature of Tavi. It's been introduced not many years back, and most of the patients who's been treated so far have limited life expectancy. So that's why it's difficult to have long-term outcome. But if you look at the PARTNER 2 trial, randomizing patient at intermediate surgical risk to surgical aortic valve replacement, or Tavi using the Sapien XT platform, you see that maybe it's coming true here, that due to this high rate of PPM with a balloon expandable valve, the risk of valve failure at 5 years is 4.7% for patient undergoing Tavi, compared to 1.3% in patient undergoing surgery. So here, higher rate for valve failure using Tavi compared to surgery. Whereas if you go to the NOTION trial, randomizing again patients between surgery, but now Tavi using the CoreValve platform, self-expanding technology, we see the opposite pattern now here at 8 years with a lower rate of valve failure for patient undergoing Tavi compared to patient undergoing surgical aortic valve replacement. So I think it based on what we have seen here about hemodynamic performance and also these very early durability data, it seems that also a difference of what kind of platform we choose in these patients if we send the patients for Tavi. So I think that's something you should take into consideration when you are faced with a patient with longer life expectancy. You want to start this lifetime management. So again, start with a valve with a good durability to bring the patient as far out as possible before you need to do your re-intervention. Any comments, Magnus or Martin, on this?
I mean, again, I think it's also important that you see in these data that you cannot be a center that only have one valve. So you should have the possibility to tailor-made your intervention and choose the right valve for the right anatomy. And clearly, I think self-expanding technology is a better choice in smaller annuli.
So when maybe the participants can post on the Q&A or in the chat what they would choose as a transcatheter valve, what they have available, and what they would choose in this patient as their first strategy.
So why we do that, Martin, we can maybe move a little bit on, because of course patient prestige mismatch is one factor, one issue you need to take into consideration, but there will be other factors as well. One important factor treating this patient is to ensure that we have access to the coronary arteries after a Tavi procedure. And I mean, it's going to be unacceptable that a patient at a younger age will undergo Tavi, and the patient later on is admitted with acute coronary syndrome, and you cannot cannulate the coronary arteries. I mean, that's not going to be acceptable. So, and we were just saying that balloon expandable valves maybe have more PPM in small aortic annuli. On the other hand, you can argue that if you have a short stent frame, it will be easier to access the coronary arteries after a Tavi procedure compared to a higher stent frame. And again, I can just show a few slides here on this. And it is an issue. We saw a few years back from Italy, this re-access study led by Marco Barbanti, very simple study, 300 patients undergoing Tavi, and the operators was asked to cannulate the right and the left coronary arteries just before valve implantation and repeat that immediately after the valve was implanted. And you can see here in 23 patients, 7.7% of the patients, they could not cannulate both coronary arteries after valve implantation. And actually, out of those 23 patients, 22 patients was treated with the Evolut platform, self-expanding technology with a supine leaflet position. So you can see for the Evolut platform, it's almost 1 out of 5 patients where you cannot access the coronary arteries after a Tavi procedure. And again, it's not going to be acceptable if you're going to treat patients with longer life expectancy. I think one of the main issues is that if you do not pay attention as we implant these valves, the orientation of the valve in the native annulus is going to be random. And you may end up in a situation, as you see here on the left-hand side, that the leaflet post, the commissures, are placed right in front of the coronary arteries. So you have what we will call severe commissural misalignment. And of course, if you have a high stent post, it will be difficult, or as you saw in the re-access study, even in some patients, even impossible to access the coronary arteries. So what I think everyone should aim for today is the same as the surgeons are doing, going for commissural alignment, try to align the commissures of the biprosthetic aortic valve with the commissures of the native valve. That's going to facilitate easier access to the coronary arteries, and also better coronary filling, and probably also better durability of these valves. So again, is going back to the heart team discussion in Belgium and in Sweden, is it something you consider, again, when you discuss how to treat this patient optimal? We were just discussing that PPM is something which is now more and more going into the discussion, having pre-procedural CT scan. But what about access to the coronary arteries? Is this an important part of the procedural planning or choice of surgery versus Tavi? And if you go for Tavi, one platform or another platform?
Definitely so. I mean, again, we try to tailor-make our decision here. And so if we have a patient who is 80 years of age and does not have pristine coronaries, the likelihood that this patient will be needing coronary interventions during his or her lifetime is actually very low. So in those situations, maybe we don't need to take that into account, and we can just then think about the risk for PPM in this patient. This patient is 67 and is also in renal failure, have already borderline disease in her coronaries. So the risk for her needing a coronary intervention is actually very high. So here I definitely would choose a technology where I can do commissural alignment, and also that the risk for not being able to access the coronaries is very low. So yeah.
Yeah, and I can add to that in Belgium we are running a clinical study in which patients with coronary disease are actually directed into an arm that does not have an intervention before the procedure, and they need to have a reassessment of their coronary status 6 months after the Tavi procedure. So for these patients, for sure, we want to choose a design of a valve which allows the access of the guiding catheter, so we don't deny our access to the coronary 6 months after the procedure. So that's for sure important. And so we also have in the chat some response. Darko, he would choose for an accurate valve because of the supraannular design and the easier coronary access.
Mm-hmm. And as you said, Magnus, I agree. For the patient we've been treating so far had been quite old, quite sick, with limited life expectancy. So if they don't have any significant lesions at the time of your procedure, the risk they will come back for intervention later on is not particularly high. I think the data I have seen, it's a 1-digit % of the patient who would actually come back later on. But remember, this is a very dynamic field. I don't know if you have seen the recent data from the US. You know, the US guidelines recommend surgical aortic valve replacement for patients younger than 65 years of age, Tavi for patients older than 80 years of age, and between 65 and 80, you should, in the heart team, try to discuss what is the best option. We saw data published just a few months ago in JACC Intervention that the clinical practice in the US is far beyond what you have in the guidelines and evidence. So for patients older than 80 years of age, it's around 100% of the patient undergoing Tavi. Between 65 and 80, it's 85% of the patient who today is offered Tavi. But even for patients younger than 65 years of age, who according to the guidelines should go for surgical aortic valve replacement, half of those patients, 48% of the patient, will have Tavi procedures today. So it's just to say that what we don't believe is an issue today will certainly become an issue tomorrow. I mean, it's going to drift down to much younger patient with much longer life expectancy. So access to the coronary arteries is, I would say, it's a mandatory. You need to have that if you're going to treat patients who have 15, 20, 25 years of remaining life expectancy. So it really needs to be considered before the first valve is going in, because if the first valve are likely to follow the patient for the rest of he or her life. It's probably not going to be explanted at any time. So maybe I can ask you, Martin, when are you try to have commissural alignment when you implant your valve to try to optimize the chance to access the coronary arteries later on?
Yeah, so we definitely do that in cases where we anticipate coronary issues in the future or existing coronary issues, but not routinely. So in elderly patients without coronary disease, we just try to get a smooth procedure. We don't spend time on aligning the valve, but when there's an indication, we do the manipulation of the device to obtain a good alignment if possible.
And I think quite a few sites are talking about how to have commissural alignment, and I think there can be at least 2 steps to do it. The first one is a very simple one, which was actually introduced by Gilbert Tang, how to introduce the delivery system into the femoral artery. So this is just for the Evolut platform. You know, when it was launched, Medtronic recommended to introduce the delivery system with this flush port at 12 o'clock, pointing to the ceiling of the room. Gilbert suggested that change that for 3 o'clock, with the purpose to have kind of a near commissural alignment for most patients. If you translate those flush port 3 o'clock for the Evolut platform to the accurate valve, it's corresponding to that you have the flush port on the accurate delivery system at 6 o'clock. So that is the first step. And Gilbert also showed that it certainly have an impact. These are the dark blue are patient where the flush port was at 12 o'clock and the light blue where the flush port was at 3 o'clock. So you can see there was actually a 50% reduction on patients having severe commissural misalignment afterwards, coming down from 40 to 20%. But it's still 20%. It's still 1 out of 5 patients who have severe commissural misalignment if you only use that flush port technique. So again, we need to do it better. And the reason that it's not going to work for everyone is that patients are different. I mean, the tortuosity of the access vessel, angulation of the aortic arch, position of the aortic annulus in the chest will be different from patient to patient. So this simple first step will, again, give some kind of near commissural alignment for most patients, but it's not patient tailored. So just here to show that, you know, that there's been a change in how we actually implant these valves. I think when we started the Tavi program years back, most sites would have the C-arm projection in an LAO cranial projection, but now it's been changed to what we call the cusp overlap view. This view determined on the pre-procedural CT scan where the right and the left cusp are overlapping. And what it's actually going to do is going to bring your C-arm down towards an RAO caudal projection for having this cusp overlap view. This was introduced in order to try to mitigate the risk of conduction abnormality and permanent pacemaker after Tavi. But it's actually also a very, very nice view if you want to have patient-specific commissural alignment. I can just illustrate it here. You see here the eye. The eye is the C-arm. You see the green dot is the right cusp and the red one, the left cusp. So now you have your C-arm in a projection where you have right-left cusp overlap view. And if you do that, as you can see here in this illustration, then you have the commissure between those 2 cusps pointing to the right of your fluoroscreen. So actually, the only thing you need to do here is to position one of the leaflet posts on your transcatheter heart valve on the far right of your fluoroscreen, whereas the 2 others should be overlapping on the left-hand side of the fluoroscreen. So it's a very simple way to do it. And with the way most sites today I'm planning the valves in this cusp overlap view, it's straightforward to do it. One of the valves which is very easy to do it with is the accurate valve, because you have some really, really clear landmark on where the posts are. So you can see here, mid-stent frame, you have those 3 posts. One needs to be on the right-hand side of the screen, the 2 other ones overlapping on the left-hand side of the screen. And if you look a little bit further down, you'll see that free stent strut on the accurate valve, which is also where the posts are. So again, one of those should be pointing to the right-hand side of the screen. If it's not the case, you can torque the delivery system just above the aortic annulus until you see it. Sometimes you need to torque up to 360 degrees, but you can do that safely. I've never seen a patient having a vascular complication related to this, and I've never seen a delivery system failing despite you did that torquing here. And again, that's going to give you not only near commissural alignment for most patients, but this is going to give you patient-specific commissural alignment. So again, you can start introducing your delivery system in a certain orientation, but then you do a fine-tuning based on each patient's anatomy just before valve deployment. And this is just a real-life example. You have a valve which is just going in, have been just implanted, and you can see how easy it is now with commissural alignment to access the left main stem here with a catheter. It takes a few seconds because you have commissural alignment. There's nothing in front of that coronary artery. So I think that is certainly a way which is now becoming routine in most institutions to have this, try to aim for patient-specific commissural alignment. I know that also in Stockholm, you have worked a lot on this, Magnus.
Yeah, no. So especially with the accurate platform. So this is something we do in every case, actually. And so this also just came out in JACC intervention, where we show that this can be done it takes at an average 90 seconds, and more than 85% of the patient then will have none or a mild misaligned valve. So it's actually very easy and to perform. You learn it in a couple of cases, to be honest. And so far, we haven't seen any downside by doing it. No increased stroke rate or aortic dissections or anything like that.
So there's one question from the audience. If this technique is also possible in balloon expandable valves to orientate it and have commissure alignment.
Magnus, is this something we can do with the balloon expandable valves?
Unfortunately, it's much more cumbersome with the balloon expandable valves. So no, yeah.
So I think there's at least two things which need to be fulfilled if you want to have this technique applied to patient. First of all, it should be very easy to identify the post on the stent frame. As I demonstrated, it's probably the accurate valve is the valve where it's easiest to see it. It's somehow feasible to see it on the evolute valve. It's more difficult to see it on the navitor valve or portico valve. And for the time being, you cannot see it on the balloon expandable valve. Second thing, it should also be possible to torque the system if you don't have it, to try to twist it. Again, it's quite easy with the accurate valve. It's more difficult with some of the other valves. But I mean, this is a commissure alignment was something we didn't talk about 3, 4, 5 years back. Now everyone is talking about it. I think industry is really much aware about this, and I think we're going to see next generation valve is coming out where this is feasible, very feasible to see it, and also to easily to rotate it so you have patient specific commissure alignment. And I think it is needed as we move forward to these younger patients. I would just to be complete, just show a few more slides, because if you asked a cardiac surgeon, he would say that yeah, but these coronary arteries are not always taking off in the middle of the cusp. So I mean, we assume that this artery is taking off in the middle of the cusp here, but sometimes you have what we call coronary ostial eccentricity that is moving to the side. And that's particularly seen from the right, for the right coronary artery, that it's not taking off in the middle, but closer to the commissure between the right and the non-coronary cusp. And we actually did a study here, 200 patients with tricuspid aortic valve and 200 patients with bicuspid aortic valve. And you can see for a patient with tricuspid valves, it's about 3% who have moderate or severe coronary ostial eccentricity. And if you go to bicuspid valve, it's 7% of the patients. So here you need to modify the technique a little bit. What you can do, instead of using this cusp overlap view, as you see on the left-hand side, where the C-arm is overlapping the right and the left cusp, you put the C-arm and you can determine that on the pre-procedural CT scan, so the two coronary arteries are overlapping. And then again, aim for having one of the leaflet posts to the right of the fluoro screen. Of course, what you're going to gain from this eccentric coronary takeoff, you're going to lose on the left. But it's better to have mild misalignment for both coronary arteries than having one with moderate or severe. You can also refine it. You can, of course, when you look at your pre-procedural CT scan or your invasive angiography, look at that right coronary artery. If it's a non-dominant, maybe you should just forget everything about the right and just focus having the left coronary arteries in line. So that's just to say that it's a little bit more tricky than just looking at it. But I think most of us as cardiologists didn't. At least I didn't know about this coronary ostial eccentricity a few years back before we start to talk about that. But if you ask a cardiac surgeon, he would tell you he knew that exactly that from what he'd been seeing during procedure.
We need to be better learning from our surgical colleagues.
I'm sure we did, and we can learn a lot here. Yeah. So we can move a little bit forward, because now I think we have talked about two important issues for this way to the patient: how to avoid patient-prosthesis mismatch, also how to ensure that we can actually access these coronary arteries, because she has some kind of pre-existing coronary artery disease, and she is also at a younger age with the risk of develop coronary artery disease down the line. She got hypertension, she got diabetes. So these were the two of the issues we had to take into considerations. We also know that new onset conduction abnormality after Tavi is also an issue and can be related with some adverse outcome. But Magnus, your group just published on the impact of permanent pacemaker after Tavi from your data from Sweetheart. So maybe you can just say what you found in your study.
So actually, in this study, it was a little bit different compared to the other studies. So here we could actually not see a long-term effect on receiving a new permanent pacemaker in this TAVR population in the long run. No, at the longer follow-up, which is a little bit different compared to other published studies out there.
Yeah. And I mean, there's been quite a lot of debate. Does it impact the outcome of the patient or not to have new onset conduction abnormality? And as you said, in the Sweetheart data, you did not find that it would impact mortality. We actually did a very similar study to what you did from our own cohort of patients. And we could see that if you have conduction abnormality after Tavi, you're going to have a worse outcome. You see here the red curve are people leaving the hospital without any conduction abnormality. But patients who have pre-existing conduction abnormality, left bundle branch block, patients who have new permanent pacemaker, or patients who have a new left bundle branch block, had the same increased mortality over the years, or here up to 7 years. And I think one of the potential confounders, Magnus, is that if you take patients who leave the hospital without a permanent pacemaker, but got a new onset left bundle branch block, and pull those patients with a patient without a permanent pacemaker, you're going to somehow dilute the signal. So I think it seems that it is as impactful on the clinical outcome whether you got a new permanent pacemaker or you got a conduction abnormality without a permanent pacemaker afterwards. So again, one study again, which is highlighting that new onset conduction abnormality or pre-existing conduction abnormality seems to have an effect. So I think this is also something we need to take into consideration. We need to try to avoid permanent pacemaker afterwards or new left bundle branch block. And this is another study, very large meta-analysis. You can see here, patient with a new left bundle branch block after Tavi. It's more than 40,000 patients. You see that at 1 year, increased all-cause mortality, cardiac mortality, heart failure hospitalization, and subsequently need for permanent pacemaker are all increased. So it's not only permanent pacemaker, but it's also the new onset conduction abnormality, which is a left bundle branch block, which is also an issue. I think we all know that it's all due to this very close proximity between the aortic annulus and the conduction system. They're actually only separated by the membranous septum, and some people would try to look at the length of the membranous septum from the pre-procedural CT scan. There will be some patient-specific or patient-related factors for the risk: right bundle branch block, short membranous septum, as I said, left ventricular outflow tract hypertrophy. But there will also be something which is related to the platform you choose. Is it a tapered inflow portion of the stent frame? Is the valve implanted deep? Do you have a lot of manipulation in the left ventricular outflow tract? Interaction with the delivery conduction system can also do it. So again, we have seen that's probably also why we see so different rate of permanent pacemaker. You can see here for the accurate valve, which we're going to see in a minute for this recorded case, the radial force is actually not the same all over the inflow portion. It's actually highest 7 millimeter above the aortic bottom of the stent frame, whereas the part which is sticking into the left ventricular outflow tract have less radial force. And also important difference between the accurate valve and the evolute valve is that the degree of oversizing is much less with the accurate valve. You see here it's somewhere between 0 and 8% oversizing, whereas if you would go for the same aortic annulus and use an evolute system, you will oversize with about 12 to 26%. So I think that's why also choice, it also matters which valve platform you actually choose for your patient when you do it. I just said before that one way to bring it down is that people are now implanting in this cost overlap view, and I think we've seen consistent with most platform, it's going to have a quite dramatic drop in permanent pacemaker, need for permanent pacemaker. Most studies will report about a 50% reduction using this view instead of the old-fashioned three-cost co-planar view. So any comments from you guys about this issue? I mean, again, I don't know exactly what's right, but I think it's something we should try to avoid if you treat patients with longer life expectancy to have a new onset conduction abnormality, whether it's just a left bundle branch block or it's a need for a new permanent pacemaker.
So one question from the audience is if there's any indication to do an EP, an electrophysiological study, before the procedure to identify those patients who are at high risk or very high risk for permanent pacemaker implantation after the procedure.
Magnus, anything you would consider to
so after the procedure or before the procedure, as we are discussing the patient?
I think we can do answer the question to both. So is there an indication to it before? And then also a very interesting comment is indeed, what if the patient has a broad bundle branch block after the procedure? Do you discharge them safely home? Do you keep them longer in the hospital because of the risk of sudden death at home? So maybe the two questions can be answered.
So clearly, I think if we have patients with an RBBB, for example, which is one of the highest risk for a permanent pacemaker after TAVR, if this is a patient where I really like to avoid having a pacemaker afterwards, I don't think we need an EP study to evaluate this any further. I just then go for the valve that I know has the lowest pacemaker rate, basically. And currently it's the accurate valve that has the lowest pacemaker rate out there. And so I would then go for that valve if it fits with the anatomy, of course. But then again, I mean, besides then obviously the ECG appearance, it's also the calcification of the LVOT, the tapering of the LVOT, the calcification of the aortic valve that also plays into account, and also the length of the membranous septum, as Lars just mentioned. These are all things that we can evaluate, but honestly, we cannot change it. The only thing we can change is the choice of the valve. So that's the only way we can affect the outcome for the patient.
So no routine EP study before the procedure. It will not help in managing the patient. No.
I think now we have talked about just 3 topics, patient position mismatch, access to the coronary arteries, conduction abnormality, that we could identify a number more. It could be paravalvular leak and so on. So I think it's a complex algorithm to choose which platform is the best for the individual patient. But I would certainly, if I had a patient where I believe there was a high risk of conduction abnormality, it could be a short membranous septum, it could be pre-existing right bundle branch block. It could also be a patient where you say this patient is not going to tolerate conduction abnormality, patient with pre-existing impaired LV function. I would certainly go for a platform which have a lower rate of permanent pacemaker. How to identify it? I don't think it's very difficult upfront to do an EP study and say who are particularly at risk. I think the only thing you can try to do is to try to implant high without, of course, having a valve which is popping up. Don't do aggressive oversizing, and also look for platforms which have a lower rate of permanent pacemakers. How to identify patients afterwards? We, as you know that, Martin, when you were working in Copenhagen, we have a very simple algorithm in the cath lab, and maybe you can just explain what it's all about.
Yeah, so we use an algorithm where we look at the patient's conduction system before and after the Tavi. So we take a routine 12-lead ECG before the procedure, immediately before, and then immediately after the procedure. And you look in the patient's rhythm. If he's in sinus rhythm, we look if there's a broad bundle branch block. We have a cutoff of around 150 milliseconds. Correct me if I'm wrong. And so if the bundle branch block is very broad in sinus rhythm after the procedure and it's new, then we keep the pacemaker, the temporary pacemaker in the groin or in the jugular vein if necessary for one night and see what happens the day after. But if the patient has a small QRS after the procedure, we just remove the permanent pacemaker and we remove the temporary pacemaker, and the patient can go to the wards with just routine monitoring without a pacemaker lead. In atrial fibrillation, the cutoff is a little bit lower. So we are, if the QRS is around 140, so it has to be a little bit less broad in the atrial fibrillation. And you can also look in sinus rhythm, look at the PR interval. If the PR interval is also prolonged, it's also a reason to keep the pacemaker for at least one night in the groin.
And I think that's a very, very, very simple. When we take a 12-lead ECG when the patient is still on the table. As Martin said, just to summarize, patient is sinus rhythm. If the QS duration is not exceeding 150, if the patient is AFib, if the QS do not exceed 140, you can safely remove the pace lead. This patient is not going to develop late high-degree AV block without a sufficient escape rhythm. So there's no risk for this patient. And that will give you the answers in at least 80, maybe 90% of the patient in the cath lab that you can make a decision here.
So are you considering not to put the pacemaker in at all in these patients?
Yeah, we won't do it. Yeah.
So that's what we do as well. So normal ECG is don't even receive a pacemaker then, and if the ECG remains normal, they leave the lab without. Pretty much the same strategy as you have in Copenhagen. Yeah, but so it's pacing on wire then during the procedure.
It'll be pacing for most patients. I mean, there will be the patient where we consider high risk pre-existing right bundle branch block. Right bundle branch block, I would say, is probably the most challenging group of patients, because we have seen data that these patients have an increased risk of mortality after Tavi. And also the increased risk is all happened within the first few weeks after the Tavi procedure. When you pass those few weeks, the curves are parallel. So I think that's a patient you think are safe, and you discharge your patient and will develop a late left bundle branch block and thereby a complete AV block with a risk of sudden cardiac death. I don't personally know how to handle this patient. I mean, some sites will give everyone a permanent pacemaker before the Tavi procedure, but remember, in the registries, it looks that it's somewhere between 5 and 10% of the patient have right bundle branch block. So if you give everyone a pacemaker, that's going to be your starting point with a pacemaker rate of 5 to 10%. So here, I think we need some more sophisticated way to identify it, and EP study could be potentially one way to have a better understanding who can be discharged safely without a permanent pacemaker, and who should certainly have a permanent pacemaker before they leave the hospital.
Yeah, or also maybe these are patients where you can consider home monitoring as well, if you have that available at your hospitals. But I agree, these are difficult patients, because we know that in these situations, even with the platforms with the lowest pacemaker rates, it's around 20 to 25% that actually will need a pacemaker after the procedure.
Mm. Any more questions we need to address at this point, Martin?
There's one question: if the patient has conduction abnormalities before the procedure but normal coronaries, would that also give you another choice of valve, or that would stay with, for example, the Acquit valve?
Have conduction abnormalities before but normal coronary arteries.
Mm-hmm.
Yeah, I mean, if you again, this is a younger patient, so it's not only about what is the status of the coronary arteries today, it's also what could happen down the line. But let's say the patient was not 67 but 87 years of age, I would probably disregard the coronary arteries and just focus on the other topics.
Okay.
So let's see what we can do for this patient here. What we choose based on also exactly the discussion we had here was that the patient would go for Tavi, not for surgical aortic valve replacement, renal function, obesity. So that was also the patient's wish, despite he was 67 years of age. That was accepted. Done in local anesthesia, as most institutions will do now. No sedation, no general anesthesia, and even in Copenhagen, we have a little bit, how should I say, simplified way. We do not have an anesthetic team in the room. There will be one of the scrub nurses sitting next to the patient and talk with the patient during the procedure, explaining what's going to happen next. You saw that the patient is suitable for transfemoral access, so it's going to be a right transfemoral access using the ProStyle. In a minute, we're going to talk about how to gain access. This patient have impaired renal function with the eGFR of 30. So we want to minimize the use of contrast and thereby also mitigate the risk of acute kidney injury. So we're going to use ultrasound guidance puncture. I think that will both save contrast compared to a crossover where you do contrast guided puncture. And also, I think we can discuss that a bit later. It's also state of the art in order to avoid vascular complications. We can talk about cerebral embolic protection in a minute, but this is the plan for this patient. We're going to treat her with an accurate Neo2 platform, moderate or medium size here. And we're going to introduce it with an expandable eye sleeve. We're going to do pre-dilatation with a 20mm balloon. For those of you who have not seen the accurate valve, I'm just going to show a picture here. It's a self-expanding technology with a supine and leaflet position. You see here in the top, in the outflow portion, you have those 3 stabilizing arches. Then you can have below them, you see the commercial post. That was what we discussed before. Very nice for navigation when you want to have patient-specific commercial alignment. Below those, you have these upper crowns, which is going to sit on the top of the leaflets, and then you have the sealing skirt below it. And you see here just below that upper crown here, one of these struts are not attached to the main frame. So that's why it's sticking out, and you have what we call this free stent strut. It's also a deployment which is somehow different from what you normally do. It's a top-down deployment. You have 2 knobs. You start with knob number 1, opening this upper crown and the 3 stabilizing arches. And then you can assess for the position, maybe change a little bit, push a little bit forward. You take this split out and you go fast on knob number 2 to open the inflow portion. So it's a very different from other self-expanding technology where you start to deploy the inflow portion and then move up. Here it's a top-down deployment. I normally say that even though it's a self-expanding technology, it's deployed a little bit like a balloon expandable valve. It's quite easy to deploy it. Magnus, I know you have a lot of experience with this platform in Karolinska, and maybe you can also tell a little bit about the iteration from the Accurate Neo to the Accurate Neo 2 platform.
Yeah, so with the I think one of the downsides with the Neo Classic, so to say, was that I would say the Achilles heel was the PVL. Was clearly not good, I would say. Now with the Neo 2, there's an improved sealing skirt that I must say has made a huge difference actually when it comes to PVL, which I think is not an issue anymore. Yeah, I completely agree with the way it's deployed. It's in a very standardized way, pretty much like a balloon expandable valve. And I also just need to point out that this is not a valve that you should try to get a position in a very, very high position. The reason for this is that it's actually anchored at the waist of the valve, and it's also where it has the highest radial force, as you just mentioned in the other slide. So if you try to put this at 2mm or 0mm, you will anchor the valve where it doesn't have a lot of radial force, and actually you could then have an event with a pop out of the valve. So basically it is positioned the same way every time, and so I think I know a lot of people are playing around trying to put it very high and so on. It's no need. The risk for pacemaker is very low anyway, the way if you position it according to IFU.
Yeah, so before
pre-dilate, it's another issue that I hear a lot of people asking about. Do you really need to pre-dilate? Of course, if you have a very low calcium score in the valve, you could probably get away with the not pre-dilating. But honestly, we are pre-dilating every case, and I think that's something you should do. Yeah.
But also, as you said, paravalvular leak was something which was of a concern in the past. It seems to be much less with this platform. And also, if you go back to the Accurate Neo or the Accurate Neo Classic, quite a few physicians will stay away from patient with severe calcification. You saw this patient had quite severe calcification of all 3 leaflets, and I would state that with the first generation valve, quite a few people would look for another alternative in these patients. So what is your experience now with the Accurate Neo valve and the Neo 2 in more severe calcified aortic annuli?
No, I think this. I mean, with the Neo 2, you can actually you can treat much more extreme patients than you could with the previous version, for sure. So the case that you just showed me is something that I wouldn't shy away from. That was, I mean, severely calcified valve with a very high gradient. Again, though, I think you need to pre-dilate this valve. Most likely, you need to post-dilate it as well. So,
bicuspid valve, is it something which could be addressed using this platform?
You could. We treat some of the bicuspid valves with this platform again. I think it's a different beast, as we all know. So you need to pick your patients carefully for these patients. So again, the very long calcified raphes and so on are maybe not the best patients for this platform, I would say. However, with a little bit of a shorter raphe, not highly calcified, these are patients that I think is very much treatable with the Accurate Neo 2.
So, and what about sizing? Because in the case you saw that even the sinotubular junction was quite calcified. If you choose an Accurate M with the sinotubular junction, 22, 24 millimeters, it was a bit borderline between small and medium. What any idea? Do you have to be afraid that the upper crown will touch the sinotubular junction? What do you think?
I think it's something that you need to take into account. So if you have a very low height of your sinus tubular junctions, so where you actually could encounter the upper crown actually touching your STJ that was small and calcified, you need to remember that the valve it actually builds 5 millimeters. So the upper crown is 5 millimeters larger than the actual valve then. So if you have a medium valve, which is the 25, it's actually 30 then. And this is also for the sinuses. So sometimes we have very shallow sinuses. So these are situations where I tend to go for the smaller valve if I'm in between sizes. Otherwise, I always go for the larger valve if I'm in between sizes. But if I have a very shallow sinus, I tend to go for the smaller valve if that's possible, especially for the very calcified valves, because I then know that I probably have to post dilate. And you can imagine if you have the upper crown pointing towards the sinuses that are very shallow and you post dilate, these are situations that you like to avoid then. But these are rare situations, but something that we look for when we evaluate the CT.
All right.
So we can maybe see the first part of the recorded case here. As I said, we're going to use ultrasound-guided puncture here, which is now become a routine in most institutions. Is it the same in Belgium, Martin?
Sorry, Lars. I was just there's one question here that I was just reading. If it's a problem, so if we have used Accurate for a very calcified valve, and then maybe you still have a restrained stent frame after the implantation of the Accurate, and then maybe it's more difficult to do a post dilatation with Accurate. That was the question I was just reading while you were continuing, Lars. I don't know if we can answer that.
What do you think, Magnus?
I can just comment on it. I think if you have a very calcified valve, I think in the situation that we will see in just a minute here, I think there is one thing that we need to take into account. Number one, we should pre-dilate. I've said this many times before. But then again, also when we detach our delivery system and that we want to take our delivery system out of the valve, sometimes if we are in the 3-cusp view, we cannot appreciate that the valve is very severely constrained. So in these situations, if you deploy it in 3-cusp view, I always go to cusp overlap view where you see the constraint of the valve much easier. And then if I see that the valve is pretty much like flat like this, these are situations where you need to be very careful retrieving the delivery system, because you can catch the stent frame with the delivery systems and unintentionally then embolize the valve. And in very, very rare situations, it could be that you cannot take the delivery system out. We have been using this valve now since many years and use it in 70% of all our cases. So these are very rare situations. It happened to me, I think, twice. So where I had to go on the contralateral side and actually balloon the valve to get the delivery system out, but it's very rare. But if you start to deploy the valve in very severe calcified valves without pre-dilatation, this is something that you could encounter then.
Yeah. So I think that was a very good tip there, Magnus. So again, if you're concerned about bringing your delivery system out, the stent holder, cross the valve again, do a pre-dilatation with the delivery system still across, and then expand it up and bring it safely out. So Magnus, questions, ultrasound guided puncture of vessels, that I guess that's the state of the art everywhere. Yeah.
No more poke and hope technique.
No.
No.
And it's probably also one of the explanations why we see much less severe vascular complication than you and I did when Tavi was launched years back. It's certainly not the same. So let's see the first part of the recorded case. This is about the ultrasound guided puncture. You saw that the GFI is low, it's 30%, so we're going to try to save as much contrast as possible. Gintas have already done access in the contralateral side using ultrasound guidance, and he's now going to demonstrate how to do it in the index side here on the right side. The patient is a bit obese, as you saw. BMI is 33. So you see there's also quite a long distance down to the skin. So it's going to be somehow challenging, but Gintas, try to talk us through what you're actually doing here.
So first is important to identify the location on the artery where you would want the needle to come to hit the wall, the anterior wall of the artery. And typically then the more obesity you have, the more distal to that artery the skin puncture should be, because of course it takes space for the needle to traverse the subcutaneous tissue. And then it's a little bit of guessing how far you should start your puncture. Again, the more obesity there is, the more distal here. I'm just a couple of centimeters distal.
Yes, we do ultrasound guide. Again, it's. I think first of all, you can ensure that you are in the middle of the vessel. You're in a calcium-free spot, so you have a high chance for a successful closure afterwards. What Gintas was doing before we got live was he took a forceps and tried to identify where to puncture. We saw the bifurcation was pretty low. It was below the caput, so he know approximately where to start to enter the skin. And now he is spending some time to really have a good puncture. As you see here, you can see the needle is coming down. So I think that's worth to spend time. And again, it's also going to save contrast. So I think we are now in a good position.
What I'm doing now is also indeed administering local anesthetic, looking at the echo, because then I hope we can do it more precisely, as was rightfully commented. And we can see that we're on the roof of the vessel, so hopefully right in the center. Okay.
You saw. So I think that's probably what happens, as we discussed before, in most institutions here, that we do that. I think it's a more precise way to puncture where you want. Again, as it is discussed, in the middle of the anterior wall in the calcium-free spot, and it's also useful when you want to have a good local anesthesia. You know exactly where to place it, and save contrast, save radiation. So any comments from you, Martin, on this?
No comments or questions from the audience on access.
I can just a small comment. So what I actually do here is actually I put the anesthesia on the micropuncture needle. So I only use that because then you can infiltrate on the way down. And actually also then when you have your anesthesia coming in, actually it's easier to see the tip of your needle. And then also you can infiltrate at the level of the artery, and then you aspirate as you go down. And then you know you have put your anesthesia exactly where you puncture later.
And then you introduce a smaller micro guide wire through that needle.
Yeah.
It's upsizing, yeah. So let's move on. I mean, as said, there are different ways to come down in profile. Some will have integrated sheets on the delivery system, and some system will have expandable sheet. And with the Acrobat Neo, as I said before, it's this eye sleeve. So we're just going to demonstrate how the eye sleeve is constructed and how to introduce it. For that, as I said, we're going to use this eye sleeve here in a second. I can just show it. It's a sheet here coming from Boston Scientific. It's coming in a 14 French profile, and as you introduce your valve through it, it's going to expand up. It's extremely hydrophilic, I would say. You need to suture to the skin, or you need to have a good grip on it when you remove balloons or a delivery system from it for it not to coming out. And I also think you saw this patient is obese. That's quite a long distance from the skin down to the vessel. And I think in some of these patients, it's actually nice to have an external sheet compared to an inline sheet, because the travel on the guide wire from the skin down to the vessel can also cause vascular complication, which is of course avoided if you have like this, a low profile introducer sheet. And as I said before, it's really hydrophilic, well, hydrophilic coated, so it's often very easy to bring it in here. And again, as I said before, I think it can be an advantage if you have a obese patient where the distance from the skin down to the vessel is long, that you don't use integrated or inline sheet, but you go for an external sheet. And so we, in some cases, even though we have a system like the Navitor valve or the Evolut valve with an integrated sheet, we will use this one here to avoid vascular complications. Yeah. Any comments on this sheet? I mean, you have used it a lot, Magnus, as well.
I think it works very well, actually. I think just one comment again. It's called the eye sleeve. It's more of a sleeve, maybe. So in very tortuous anatomies, I think both you and I and most of the centers worldwide are using a safari wire as a routine. But these are situations maybe where I would prefer the Lundqvist wire than, and always remember to leave a wire inside of the sheet at all times. Don't withdraw the wire, because these are situations where you can kink then your sheet. But no, I think it's a very good sheet, actually. Yeah.
And one comment maybe also at the end of the procedure, when you retrieve the delivery system or balloons, to always be careful when you retract it into the eye sleeve and the tip, because it's an expandable sheet. If you feel resistance, don't pull too hard. Have a look with the fluoroscopy if your balloon or delivery system is nicely entering the eye sleeve, so you don't damage the eye sleeve.
Okay.
So also this sheet has been used in a quite unique way. Some sites will use what they call a one-hole technique with this. Is this something you have been using, Magnus?
Actually not, no. So I'm aware of the technique, but I haven't used it myself, actually. Yeah. So our second axis is always radial. But I mean, this is one way of simplifying it even further. I'm not sure, though, if it's one step too
maybe
far.
You can explain what it's all about.
So the way it is that you actually use
one-hole technique.
Yeah, the one-hole technique is basically so through the eye sleeve, you don't not only deliver the valve, but you also have your pigtail in the same sheet, basically, and that in that way you avoid having another extra arterial access, which is in that way you can speed up the procedure. There are some complications with the secondary arterial access as well, and so on. So it could be some benefit there. I can see some problems maybe that I think it's quite important to really have your pigtail in the non-coronary cusp at all times, and in some situations also. May I freeze up here?
No, we see you.
You see me? Okay.
Yeah.
Yeah, okay, right. You freeze up. Yeah, so in some situation also, maybe you would like to, the patient maybe is not doing well and you like to speed up the procedure. I think these are situations where you don't want to fiddle around with trying to get the pigtail in the right place. Having said that, though, I have personally no experience with the technique. I think it's intriguing, but maybe I would like to try it in the bench a little bit before I try it out in real life, actually.
So let's move on. I said we're going to use cerebral embolic protection device in this patient. And where are we with cerebral embolic protection today, Magnus?
Oh my God, I was almost hoping you wouldn't ask me, actually. Yeah, but I kind of knew you would. Yeah, this is really hard, actually. I mean, again, after the studies that we have had presented and published, I think it is difficult. Again, we see a reduction in the disabling strokes, which are the ones that actually we would like to reduce. These are the ones that actually do a lot of harm and keep the patient in the hospitals and so on. And we see a reduction there. We don't see a significant reduction in the entire stroke group, which was a little bit of a disappointment, I think, for all of us. I do think, though, that this what it also showed is that you can use cerebral protection with an extremely low risk, actually, which was almost surprisingly low risk, which is reassuring, I think. So to me, my take is if your your institution can take the cost. This is something that I would actually still use in every patient then to avoid having a disabling stroke. I know the health economist maybe will not agree on me on this one, but this is actually my take on the studies.
So and if I can ask a question on that, Lars. So is there any possible way in the middle so that health economics is not that of an issue? Can you identify groups and can you give advice on the participants in which patients they should for sure consider cerebral embolic protection, or were there no subgroups that show the benefit in the study?
I mean, we saw that what Magnus is referring to is the protected TAVI trial, which was it had primary endpoint of all-cause stroke, but all stroke, and there was not a statistical significant benefit of using this. Secondary endpoint with disabling stroke was significantly different with lower with this. Again, event rate was very low, and that's probably why it's so difficult to prove it. Anything, it's around 2.8% in the control group and 2.2% in the central group for all strokes. So it's hard to make these sub-analyses. People will, if you ask people, say that patient at particular risk for stroke are patient with bicuspid aortic valve, valve-in-valve procedure, severely calcified valve, patient with previously stroke. So those were the patients where some sites will use it if they're not using it in all sites, but in selected patients. But again, it's not supported with the evidence we got so far. But as Manu said, it's a very easy way to implant. It's really safe. I'm just going to show or demonstrate how it was done.
And we're going to
see. We're going to. Let's see where.
And we're going to use the sensor.
Oh.
And we're going to use the sensor device. We're going to avoid to do this aortic root injection to identify the neck vessels. We know the anatomy from the pre-procedural CT scan, and this AL1 catheter is going to sit in the outer curve of the aortic arch as a landmark. So having the CT scan and this catheter means that we again can do this step of the procedure without any contrast. We've got a 6 French sheet now in the right radial artery, and
this is just a BMW wire, a coronary wire. Yeah, I'm gonna go in. Go smooth. I have a little resistance. Wait a second. No, I go smooth. Yeah, go smooth. Yeah.
You see the wires coming up here.
Mm-hmm.
And down to the eighth inning aorta. Again, there are 2 filters. The proximal filter is going to sit in the brachiocephalic trunk, and the distal filter in the left common carotid artery. So it's going to cover 3 out of 4 neck vessels. The only vessel which is not covered is the left vertebral artery. So there are 3 steps here, Ole.
Yeah. So we have slider 1. I will do it immediately. That exposes the most proximal filter in the brachiocephalic trunk. Goes here. You see the AL1 catheter at the meantime in the outer curvature of the aorta. Now we make sure we pull in the entire wire. That's the case. So then we start flexing now with knob number 2, just to get the flex. Like this. Maybe we're a little bit downish, so I'll split the handle a tiny bit, and I torque the handle now because we're not perfectly.
I think the filter should come a little bit up. Yeah, I guess so.
Yeah. Yeah, you can try to wire it now. Yeah, I can push maybe more. Wait a second. We know that the coronary makes such a small bend on the CT. So okay, so now we're a good flex. Now we're going to split the handle to bring this curve to the carina and the outer curvature of the aorta. That's it. And now in this holds the wire, we gently come out with the most distal filter.
Number 3 here.
Yeah, number 3, we push it out.
So we see it takes only a few minutes to put it in, and we have also seen from, even though we don't need to discuss the Protect TAVI trial in details, we have seen that it's extremely safe to do it. I mean, the risk of vascular complication is again close to 0 here for using the device.
So again, it's nothing about the time consuming, the risk of it. It's all about do we believe in it? And I think, as I see it, we had this protected TAVI trial, 3,000 patient randomized 1-to-1. I think what everyone is probably now waiting for is the British Heart Foundation's Protect TAVI trial running in the UK. It's going to add 7,700 patients with similar outcome, or the same outcome as Protected TAVI. And there's already planned a meta-analysis of those 2 trials. So it's going to give us almost 11,000 patients. So we're certainly going to have the power to demonstrate whether it's effectful to use it. Of course, again, we don't need to discuss the Protected TAVI in details, but one thing which was not captured in that was what is the long-term outcome of these so-called silent brain lesions. I mean, if you ask a stroke neurologist, he will say that they are not silent. They're going to put the patient at risk for early dementia, cognitive impairment, and that was not captured in that protected Tavi trial, and it's not going to be captured in the UK trial. Those both trials stop at 72 hours after the procedure. So, but again, a lot of things to discuss here, and again, also I think if you ask a patient, elderly patient, what are they most afraid of for the procedure, it may be not as much of the mortality, but having a disabling stroke is the most fear. So again, we use it routinely in patients where it's anatomically suitable to do it in Copenhagen.
And you can also elegantly show here that you can do it without adding any contrast to the procedure, which I think it's very nice.
So, Magnus, should we go to the procedure itself and see how to deploy this valve?
So next here from the contralateral side, 6 French sheathers in. We're going up with a pigtail catheter. Nothing special here. It's going to sit in the non-coronary cusp as a landmark, and also can be used for ejection. One of the good things is about the severe calcification. We have quite good landmarks on the calcium itself. So hopefully we can once again save contrast during the procedure. So next will be to cross the valve. Ginta's got an AL1 catheter with a standard straight wire. Working in and one of the things we're doing only as a routine now when we cross the valve is to start in a right to left crossboard view. So can you explain why that's an advantage?
Yeah, we do like it because you see we position the pigtail in the non-coronary cusp, and then we know the right and the left are overlapped. We understand fully the native anatomy of that patient. So typically, as you see, you cross where Ginta's crossed, so just next to the non-coronary cusp, because you look into the commissure between the non and the right and the left, actually. So
you have the non-coronary cusp isolated on the left hand side of the screen, and the right and the left is overlapping on the right hand side of the screen. So you know where to search for the opening. Again, we're going to do it in 2 steps here. We're going to introduce an exchange length J-tip wire into the LV and then go in with a pigtail. So we're not going in with a stiff wire directly. One reason is that we want to have a safe introduction of the stiff wire in the LV with no risk of being entangled in the mitral apparatus. Since this patient is treated under local anesthesia, we can only assess for paravalvular leak afterwards using aortic root injection and hemodynamic performance. We cannot do transesophageal echo. So hemodynamic assessment is going to be an important part of the assessment of PVL. So what we're going to do now with the pigtail here is that, of course, we're going to measure the gradient. We know patients have severe aortic stenosis, but maybe more important, we're going to recall what is the diastolic pressure in the aorta and what is the end diastolic pressure in the LV, and then compare that to what we see afterwards.
Should give there's a small look in it.
Yeah. So again here, let's see hemodynamics. Good stable. So certainly there's a high gradient as expected here. So we can do some recording, and we can see that the pressure in the aorta is 99. Pressure in the LV is 172. So a grade of 7 to 3 millimeter mercury. But as important, diastolic pressure in the aorta is 26. It may be related to a little bit of bradycardia, and end diastolic pressure in the LV is 7. So 26 and 7 are the 2 numbers we're going to recall for comparing it afterwards. So we have
bring in a small wire already, maybe.
Yeah. Once again, we're going to do LV pacing. Gintas is connecting one of the crocodile connection here to the short guide wire sitting in a short venous sheet, and the other crocodile attachment is going to go on a stiff wire in a minute. So we're going to use our default guide wire, which is a Safari guide wire from Boston Scientific, pre-shaped wire, giving a good support. I think that's the default stiff guide wire, not only in this institution, but in most institutions in Europe. I know in the US there's a trend to use this double curved Lundquist guide wire, but I think this wire works fine from us. So I think we are almost set now to do a pre-dilatation. Again, this is a 20 millimeter straight balloon. It's an Osipka balloon. Yeah. Yeah.
Let's continue.
Really going. So again, 20 millimeter balloon, a super balloon here. We're going to place. You can just connect the second crocodile up here to the stiff wire. You ready? One?
Wait a second.
So when you're ready, you can try to place 180 max output, Sophie.
You ready on it?
Mhm.
Face on. Capture.
Yeah.
Balloon up.
Oh, I see. That's really
Down.
calcified.
Face off.
Wow.
Should we maybe
Yeah, because maybe should we do it once more?
Yeah.
It was very stable balloon.
Good.
Maybe 160. 160. Er du klar? Face on. Capture. Balloon up. All the way.
That's all the way.
Balloon
Yeah.
down. Face off.
Yeah.
Floor safe.
Yeah, I didn't go all the way the first time, but this time I went all the way.
Okay, she's in normal rhythm. We disconnect pacer. Sophie.
Okay, Fleur.
So Ole, before you introduce it, maybe we can just ask Martin to zoom in on the tip of the delivery system, and you can explain what we actually see here.
这个做完了，它的前降支啊，
This is the small loader.
当地的人呢，
The small loader, the valve is in here, and that's the nose console. The stabilizing arches are completely covered. This is the small seal, outer seal that you see. So now we're advancing this. We have the flush port at 6 o'clock.
So just
Wait a second, Guinness.
So with the people talking about commissural alignment in order to have better access to the coronary arteries, maybe also better durability of these valves. For Medtronic, the evolute valve, it was suggested not to have the flush port at 12 o'clock, but going to 3 o'clock to have a better chance for having near commissural alignment in most patients. For the Agra valve, the flush port is down here, so that should be, as Ole said, 6 o'clock. You can also have it at 10 o'clock or 2 o'clock, but 6 o'clock you can certainly easily identify it. So 6 o'clock here with the flush port is the first step to have near commissural alignment in most patients.
Okay, so now Guinness is going in with the loader.
Sheath. That much. Then if we continue, we can actually show how that big sheath, how the valve comes out of it.
And often will be a little bit resistant as you push through this expandable sheet because it needs, of course, to expand up. But you see now it's in here. Yeah. So the next step will be what we call patient-specific commissural alignment. Again, flush port 6 o'clock will give a kind of a near commissural alignment for most patients, but we want to tailor the commissural alignment to each individual patient. So if we have a few more slides, we can share with you if you can bring those up. Yeah. You see, this is the accurate NEO2. So you need to know where are the leaflet posts on the valve. And there's 2 positions you can identify it. You can see the post mid-stent frame. There's those 3 posts here. And you can see below the post, there are what we call the free stent strut. There's one of the struts which is sticking out from the stent frame. So we need to make sure that these commissures are aligned with one of the commissures in the native aortic valve. So again, we're working in this right-left cusp overlap view. You see the eye is the C-arm, and the green dot is the right coronary cusp, and the red one is the left one. So you see we have this cusp overlap view. The right and left cusp are overlapping. And working in this projection, you can see that the commissure between the right and the left will point to the right of the fluoro screen. So here in this projection, we know that the only thing we need to do is to make sure that one of the commissures or leaflet post on the transcatheter heart valve is positioned on your right of your fluoro screen. That's going to give you patient-specific commissural alignment. I'm just going to here, this is the accurate valve. As I said, you can see the post mid-stent frame. 2 posts should be overlapping on the left-hand side. 1 should be isolated on the right-hand side. You see the free stent strut. 1 of the free stent struts should be isolated on the right-hand side. That's going to give you patient-specific commissural alignment if you're working in a right-left cusp overlap view. So we can demonstrate it here how we do it in real life, Gentes.
So first, of course, we are going to cross the arch. This is indeed a very flexible system. Normally, we don't expect too much trouble crossing the arch. It goes very easily, very minimal amount of resistance. And
this is cusp overlap.
it's cusp overlap. So we're not far. Actually, we're almost.
So again, you see in the top of the screen, you see those 3 posts. You want 1 on the right-hand side of the screen.
Mm-hmm.
2 should be overlapping on the left-hand side of the screen. Below, you see that, just do a short scene, the free stent strut sticking out. So that should be isolated here. So here you're
Almost
pretty
there.
close.
We almost there. We're pretty close.
If you're not close, what are you going to do? Just demonstrate on the handle.
So we would rotate. Once we come a bit lower down, we would rotate the handle, and then depending on how much we need to turn, it can sometimes be even a full turn. But
yeah, maybe just seeing while you rotate just to illustrate how, and it may be easy to look at the top part that now it looks like those. And how much are you rotating, Ole?
Yeah, this was actually less than normal because we need a very little, I mean, I would say 90 degrees of...
sometimes you go even up to 180 degrees to
or even 360.
360.
And we seem to have 2 posts now overlapping on the
Let's
left.
do a short scene just to demonstrate it. So you see 2 posts overlapping on the left-hand side. 1 is actually on the right-hand side. You have 1 free stent strut pointing to the right-hand side of the screen.
Activate the contrast.
Let's go a bit deeper, maybe.
And just say how are you going? What is your navigation point here?
So we can see the marker
in the middle of the stent frame. Yeah,
That radiopaque marker.
That radiopaque marker. That marker should be positioned right above the annulus, basically. So, and the annulus is indicated by the pigtail. So we will soon make an injection, but the pigtail hopefully sitting deep in the non-coronary cusp, and it should tell us where the annulus is. Of course, without making contrast injection, we can't be 100% certain. That's why we will make at least one contrast injection. And then we want basically the black marker to be at the bottom of the pigtail level, so to say. Matching the thickness of the pigtail. So we're approaching very slowly. It should be a slow approach. We will also want to see the top of the stent above the visible calcified leaflet markers, leaflet edges, which it appears to be. And now let me make a first injection here. Oh.
So you see, there's a little, but we just have to notice that there may be one millimeter down to the bottom of the cusp, but
we have space. We're still above the calcium, above the rims of the leaflets. Not much though. We're nearly perfect there.
Yeah.
What do you say?
No, I think it's quite okay. I mean, you should go live again. Yeah, for sure now it is good. It looks good.
And it's also important always to keep a forward push in the system. You should not drag it back. If you drag back, you need to go further back and then have a forward tension in the system.
Okay, so we open up the upper crown now. Okay.
Yeah. So knob number 1 is going to open the upper crown and the stabilizing arches. So it's a top-down deployment.
Yeah, that opens nicely.
The upper crown is coming out here, you see. And it's against us saying we want them to sit on the top of the calcified leaflets. And next you see the stabilizing arches are released like this.
Yeah.
Yeah. So go to full stop here. And then we can all of us remove that safety split here to be ordered to rotate wheel number 2.
Contrast.
You want to check once again that we are where we should be with the contrast injection.
So I could do contrast, and if we have, you can deploy in the same run. So then we'll see.
I would definitely give a little bit of push on the.
So I'm already applying a little bit of push forward.
On our wire, we have a little bit of push already.
The wire is making that
bend. Yeah.
I'm pushing really, and it sits nicely on those leaflets. So I do injection. We have you
without pacing. It's just
injection.
Yeah.
I'm happy.
All right.
You go.
You want to go?
Yeah. That's good.
Good. So
we can see a couple of things. It's first of all, it's a nice commissural alignment, which is pretty perfect. We have precisely overlapping posts to the left and one exposed to the right of the screen. The valve is sitting exactly on the top of the calcified rims of the leaflets. So position is also depth-wise as it should be. The stand holder, which is a blackest visible metal part of the system. Oh, careful.
It was difficult to get the wire. Yeah.
It appeared to be detached from the stent into the ventricular end, and it seems to be coming out nicely without major resistance, which is also suggestive of a nice release from the system. So all good, all stable. We're happy there.
And there's no need for pacing here, so we can detach the crocodile and you do the closure wheel. That's exactly opposite. Wheel number 2 now is going clockwise, and then wheel number 1.
Yeah, and now with number 1 clockwise, we bring back the system. We close it, so it's safe to remove
like this
through the sleeve. Yeah.
Leave the wire. And the question is whether we want to assess first, or we just want to go in with the same 20 balloon
I would go with the same 20 balloon, to be honest.
And also to save a little bit of contrast, so we don't do so many assessments. accurate valve in these kind of anatomies. But as I said, this has been a game changer for Boston Scientific to enhance the sealing skirt. Next is to remove the eye sleeve. I think one thing which is very important with these expandable sheet is to introduce the dilator before you remove it, not to that those folding on the sheet can cause vascular complication as you pull it out. Again, Gintas, just explain us your strategy for vascular closure.
Yeah, so in this particular case, we used 2 ProGlide. I very often use just one, but here it was a less certain puncture due to the depth of the puncture. So just in case, we used 2. I think I will start with just closing one initially. We will move out with the knot pusher. Yeah, we will move out with the big sheath. We will see how it looks like. Most of the time, we put a 6-strand sheath in, which we use to check the result. I will close also afterwards ProGlide number 2, and depending on the result, we may or may not use AngioSeal on top. Very often, I would use just 1 ProGlide and 1 AngioSeal. That's my preferred strategy. In this particular case, we have 2 ProGlides up front just in case. And as we close one, it already stops the bleeding pretty nicely. As I'm pulling on it, there's not much to see outside. I still have 1 more ProGlide left to me. So I think I'm gonna close that one too.
So 6-strand sheet went in here on the stiff guide wire, an Armclast super stiff guide wire.
Yeah. So now number 2, ProGlide number 2 is also closed around that sheet. We will check with contrast injection, small one. So as of right now, with the 6-strand sheet in, there's absolutely no bleeding. So I would be tempted to use an AngioSeal to keep it like that. We'll see. Well, let's make an injection, a small one with some hand contrast.
Yeah, that's 5 cc of contrast. You can change it.
Yeah, that's good. That's good. Mm-hmm.
So that's where the 6-strand sheet or the stiff guide wire dilator went out.
Yeah, so it's a good flow.
Yeah.
There's, of course, 2 ProGlides. They cause a little bit of pinching, but very fast flow. There's clearly no stenosis there at all. So we can remove the 6-strand sheath and finalize the closure of the ProGlides. We'll see how it looks like. Let's keep the wire for now. Sure. If there would be bleeding, then we can easily just put the AngioSeal. See a little bit of oozing. I think it's slightly too much for me. This would probably go away if we would keep compressing for next 15 minutes or so. But I would be tempted here to put just an AngioSeal. Let's see if that changes the situation. Then most of the time with AngioSeal, we can immediately achieve a complete hemostasis. Not always, of course, but in most cases. So let's see. This comes out. Yep. So yeah, we put an AngioSeal, and indeed now externally at least we have complete full hemostasis. So now we don't need to compress anything.
I mean, we have no bleeding now. We're sure that it's not going to bleed, but of course we also make sure that we have a patient vessel. So so we can maybe demonstrate, Gintas, with ultrasound how to check that flow in that vessel here.
So let's get the ultrasound probe then.
Yeah.
This is our vessel.
Mm-hmm.
On the cross-sectional view. The vein is on the medial side, on the right of the screen. The artery is on the left of the screen. And now I'm scanning through that artery. I'm going lower, way lower past my puncture site, and there's still a nice pulsatile flow. This is already lower than the bifurcation. You see there are 2 branches, and they're both showing nice pulsatile flow. I'm coming back up. This is where the bifurcation is, right there. So there's only 1 branch remaining right here, and it still flows through its entire length. Of course, I could go in the long axis as well. It's also possible to show, but of course, due to BMI more than 30, it's sometimes a bit tricky to properly align the whole vessel.
And I also think the plug also gives some sharing just where it's okay.
Yeah. It's a nicely pulsatile flow that we can see throughout its entire length in the groin region where we had access. So no visible extravasation and no visible occlusion to be seen.
As a routine, we take an ECG in here in the cath lab. We can see that the QS duration is 150. So that's just on the borderline. So we don't expect this patient to have late high degree AV block. So the patient will leave the cath lab without any temporary pacemaker. This patient will go straight back to the ordinary ward. There will be no recovering room. There will be no ICU. Straight back to the normal ward where she was this morning. She will be mobilized in 4 to 6 hours, and tomorrow morning she will have an echocardiography and be discharged to her home.
Okay. Any comments, Magnus, on this case? Anything different from what you're doing in Stockholm?
No, I think it's a very nice case showing this valve in a quite extreme anatomy, I have to say. And then, as we discussed earlier, I suspected a post-still in this very severe calcific valve, and I would have done the same. I wouldn't have done an angiogram in this patient with the renal failure. I would just have post-dilated with the same pre-dilatation balloon. And because you could see that the valve was quite constrained. So clearly you needed to post-dilate it, which was expected. But again, a very nice result with almost no PVL, good gradient. So clearly a nice result. So.
Martin, any comments on the chat?
Yeah, I have two questions. So if I was seeing correctly, so the valve was implanted in cusp overlap view. Is that something you would recommend to starting centers?
I personally feel that the cusp overlap view give you a true understanding where are your valve position, because you don't have that parallax in your delivery system or in the tilt in the aortic annulus. So you're often working very close to this double S-curve crossing, so you have a better understanding. So I think no matter what valve you're using, I think you got the best understanding where are you actually, how deep are you with your valve, or how high. So that's my routine. I know some people will follow the old IFU or the current IFU from Boston Scientific and implant in a three-cusp coplanar view. Well, what are you doing, Magnus?
I think, yeah, so I agree with you here. I mean, I think we use both, actually. So we use both the cusp overlap and the three-cusp view when we do this. I do think that when you start using the valve, usually you have someone there proctoring you. And I think one downside with the cusp overlap view is, as you mentioned in this live case, is that it's very important to always maintain forward pressure on the valve. And this we can appreciate in the three-cusp view, because we can see that the wire is in the outer on the outer curvature of the aorta. When you are in the cusp overlap view, you cannot appreciate that as easy. That's why it's a little bit more difficult for someone teaching you and explaining to you, this is a good forward pressure, this is too much and this is too little. So that is maybe for the first couple of cases, at least, I think you should try doing it in three-cusp view. And then when you start to get a feeling for it, you can move over to the cusp overlap. Yeah.
And another question is, what about holding a small pause between the upper crown and the stabilizing arches? Is that something you would recommend, or you just deploy knob number 1, upper crown and stabilizing arches in one movement? Or do you pause, do the upper crown, adjust a little bit, and then do the stabilizing arches?
I do it like in 2 steps then. So I do a 1A and 1B. So basically what we were shown here, but maybe more of a pause. Again, this is a case with a poor renal function where you do not want to give an extra amount of contrast, but otherwise I make sure I'm in the right position. I deploy the upper crowns, the 1A deployment, double check again with contrast, and this can be like 5 to 7 cc's of contrast. Doesn't need to be more than that. And then if I'm happy there, now I deploy knob 1B, so to say, so the stabilization arches.
There was also one question from the audience on closure. I don't know if we can move to that question now. The question was, what if your pro glides fail? So at the end, you pull on the strings of the pro glides and you have them in your hands. What to do?
Again, if you still have your guide wire in place, as you saw here in this case, you have the options to go in with a new pro glide in place. What you see here, we have a low threshold to top up with a plug device. An angioseal can be a 6 French, can be an 8 French. We even have cases where we see it's complete failure closure. We go in with a Manta device afterwards to have an even bigger plug device.
All right.
So here is where I maybe do it a little bit different. So we are a Manta first center, but I think they are pretty much similar. The failure situations are a little bit different though, but yeah.
And would you recommend crossing over if you plan to use a Manta up front? Do you put a safety wire, or you don't?
No, we don't. So our normal setup is a radial artery and femoral artery then for the procedure. And then we also, like you could see here, we actually check our result with ultrasound. So with ultrasound, you can also deploy the Manta with ultrasound, and then you can check the result also again with ultrasound. So in the standard case, we don't give any contrast at all. So if we need to give contrast, or if we need to balloon the access site, we do that normally from the radial artery using longer balloons then. But then if we need to stent the access site, these are situations where we puncture the contralateral side and go contralateral, or you puncture below your access site, and then you can stent from there as well. That's another option.
Good. I mean, I got a few slides here back, and we are approaching the end of this webinar here, but the first one is we're talking about a younger patient and talking about lifetime management. So if the patient will live long enough, she will probably outlive her transcatheter heart valve and what to do afterwards. And as I mentioned this before, this is the American guideline, how it divides patients into 3 groups: younger than 65, surgical aortic valve replacement; between 65 and 80 years, heart team should discuss surgical or transcatheter aortic valve replacement; and more than 80 years of age, it should be Tavi. But as I said before, real-world practice in the US is far outside the guidelines and the evidence. So for the elderly patients, it's almost 100% of the patients undergoing Tavi, even in the patients between 65 and 80 years, where it should be a discussion of the 2 treatment options, it's 87% of the patient undergoing Tavi. And even for the younger patients, it's close to half of the patients undergoing Tavi. So certainly that's something we're going to see much more common in the future, that these transcatheter heart valves are going to fail because the patient have a longer life expectancy. And in principle, there are 2 ways to treat the patient. You can send the patient for surgery, ask the surgeons to explant that Tavi valve and implant a surgical bioprosthetic aortic valve. At least the data we've seen so far is rated with a quite high mortality rate, 30 days mortality rate of 13%, despite you exclude patients who have redo surgery or surgery due to acute endocarditis. Of course, it's also because it's quite older patients with comorbidity, but still, it's not a walk in the park to explant Tavi valve, which has been in there for many years. It's often involving root replacement for these patients. So redo Tavi is probably the way forward. I'm just going to show a few slides here. What is a concern? So when you implant a second valve inside it, and I think most sites will nowadays consider that the second valve should be a short stent frame, a balloon expandable valve. You can implant it low or high. The higher you're going to implant it, the higher is what we call this new skirt going to be. The new skirt is the tissue from the first valve, the tissue from the first valve's leaflets, which is going to be jailed between the 2 stent frame. And if you have a high new skirt, your access to the coronary arteries is going to be more difficult. So you can implant low to have a lower new skirt and thereby easier access to the coronary arteries. On the other hand, if you implant lower, some of the leaflet from the first valve is going to overhang the second valve. You're going to have that leaflet overhang, and since it's often thickened and degenerated leaflets, that may potentially impact the hemodynamic performance after a valve-in-valve procedure. So it's going to be a balance about the height of the new skirt and the degree of leaflet overhang. And we just tried to simulate here for 4 platforms: a Sapien platform, a Navitor, an Acrobat, and an Evolut platform, all assuming the first valve is failed, and all valves are going to be treated with a second valve, which is all a Sapien platform in a low position. So you can see here, what is the height of the new skirt going to be? What is the degree of leaflet overhang going to be? And how big are these stent cells where you actually need to passugate into it? So I think that's a discussion or a consideration you need to have already before the first valve is going in. What are you going to do when this valve is going to fail? What is the chance to do a TAV-in-TAV procedure and still have access to the coronary arteries, and also do not impact the hemodynamic performance by too much leaflet overhang? I don't know if you...
No, I mean, again, this is something that we will encounter much more in the upcoming years. Obviously, since we've been using the Acrobat valve for many years, we have also had a couple of cases where we needed to do a valve-in-valve procedure. I actually did one just this week, actually, in a patient that had an Acrobat 6.5 years ago that now failed and had a prolapse of one of the leaflets. So it was a pure regurgitation, where we actually were able to put the Sapien in lower in a quite low position with a good result. The interesting thing with the Acrobat valve is that the failure that we have had with this valve have all been regurgitation actually so far, which is actually different compared to the other valves, and we'll see if that holds. But so far, I think it's around 7 or 8 valves that have failed, and all of them have been regurgitation.
So there's also one question from the group. What is our opinion on TAVR in Perceval valves? So I don't know who of you guys wants to take that question.
So I guess this is what they call the sutureless surgical valves. We have not been using that in my institution. I have no personal experience with that. I don't know if you, Martin, or you, Magnus, have any experience with it.
Martin, go on if you have.
No, I don't have experience with Tavi in Perceval. No.
Okay. We have done a couple of cases, and actually, it's surprising. We just had one at this week's MDT failed. So I think it's a quite a standard. It's very much similar to the way you approach the Acrobat valve actually. So it's a little bit hard to describe now without any pictures, but it's actually not completely complex. But I usually would treat this with a balloon expandable valve.
Good. I think we are approaching the end of this webinar. I don't know if you, Martin, or you, Magnus, have any final comments on before we close down. And
No, the questions from the audience have all been answered.
okay.
Thank you.
So Magnus, thanks a lot, and Martin, thanks a lot for being part of this. I hope also for all of you who joined this webinar that it was useful, that you learned something about contemporary TAVI, particularly how to address patients with longer life expectancy, how to identify issues which can be something you need to consider before you choose your first valve, and also how to optimize your procedural steps to have the best outcome for the patient, and also looking into the future, what's going to happen next when the patient will have a failed valve or need to be treated for coronary artery disease. So again, thanks everyone for joining. Thanks for CSI for organizing this webinar, and thanks to Boston Scientific for sponsoring it. Thank you.
Thank you.
Bye-bye.